Before we get into the case of the month, I want to tell you about three quick things. First of all, guided imagery. These are the halo procedures, the high acuity, low occurrence procedures, where Jess goes through in a very melodic way. You close your eyes and you go through step 1, step 2, step 3. This is a really new, interesting way of thinking about how to do procedures that you rarely get to do. And this is a way of doing it in your brain with Jess taking you through those. The second thing is in Compendium. We just released 15 or 16 chapters on ultrasound guided nerve blocks. We think it's the best resource online for ultrasound nerve blocks in the history of the world. And then coming soon, ultrasound fundamentals, like how to do the basics of ultrasound for newbies, but also for people who never really learned it that well. That is coming really soon. And then Infectious Encore, which is our oral board review prep course, plus a whole bunch of resources around that, a whole bunch of cases, a lot of videos. Encore will be dropping real soon. Let's get to the case of the month. Robert, out.
Today's October 6th, and we can go all the way back to 1866 for our little banter to start today, because that was the date, October 6th, 1866, of the first train robbery in the U.S. by the Reno brothers. And Jan, this made me think about train heists and how I love where movies are kind of based around a train heist kind of idea. Like it's a central theme to the plot. I'm thinking like Bullet Train, Mission Impossible, Murder on the Orient Express. Jan, you got any of your favorites that are kind of train based or train heist?
Yes, I have another one that is... especially because Gene Hackman died recently, and so Narrow Margin was a movie that he did with Ann Archer that was also on a train. I agree with you. I like train movies. I'm also thinking about action movies where sequences are happening on top of the train. Also enjoy that.
Very cool. Yeah. There's something about that. You look at that and you're like, could I do that? Could I walk on the top of a train to do something? I don't think that's possible. I really don't think. I think the movies have made it seem possible, but I think you're dead pretty quick.
Yeah, as soon as you see that smack of like, they hit against something as the tunnel is coming, you're pretty much like, okay, that would be me. I would for sure stand up at the wrong moment. But you do think about it. You think about it doesn't look that hard. When they get up there and they're like walking on top of the cars, you're like, yeah, that's what I would do.
Just a little balance. That's all you need. Just a little bit of extra balance seems fine. I mean, now I'm going to have to say that I can't even stand straight and not fall over on the inside of a train. So like I'm on a subway car, I'm probably falling all over the place. So maybe I shouldn't go on the outside of the car. So maybe that's on me. But I do think when you set up the movie with a train scene, it's got to be a heist. And there's got to be some point where they go outside the train. Like if that doesn't happen, you're like, you totally botched this. How could you have a train and not go on the outside of the train?
Yeah, for sure. You're just expecting it. At what point are they going to transition this scene to the outside of the train, and you're just waiting for it to happen? Or the jump off the train with the roll, like an old Brother, Where Art Thou?
Right.
That kind of a thing.
You're definitely dead after that one too. Yeah, 100%. Well, for the listeners out there, I know October is Halloween, and we want to think about all the horror movies, but if you have train movie recommendations, we're here for them. We might make this like National Train Movie Month for Jan and I. So send in your recs. We will watch all of them, and maybe we'll come back with a little bit of a scale, rating them on like a 1 to 10. What's at the top? What's at the bottom?
Oh, that sounds super fun. I'm totally into that.
All right. Well, Jan, let's jump into our case to lead into the week. We have some great stuff on tap, and you've got a case for us.
I do, Swami. You're working in Fast Track. It's your favorite place to work.
Always.
You're seeing them, you're moving through the meat, and you see the chief complaint pop up of penile pain. You're like, okay, penile pain, I got this. This is probably, something STI-related, maybe a UTI, I don't know. And this is a stable, very stable, vitals normal, 58-year-old guy coming in with a complaint of penile pain. And it's a wound, he says, on his penis. So you're a little more intrigued. A wound, that's interesting. It's been developing over the last few months. So it's not brand new, but he's got a lot of pain. So I want to know what your differential is of this and what you're thinking and what kind of questions you want to ask this patient.
I mean, I think the differential is really going to rely on the exam. But the things that I'm going to ask before I get to the exam, because you can't just like bring the person in and be like, drop your drawers, let's take a look. You got to ask some questions going into it. So I do want to know sexual history. Even though it's been going on for a couple of months, I kind of want to know about that. Whenever we think about STIs and penile lesions, we think about painful versus painless. Now, clearly, pain is what brought this person here. So we can kind of take off all the painless lesions, take those out. Trauma, was there trauma or a burn or something like that? I mean, you don't know what people get into, so you got to ask those kind of questions. I think as a resident, sometimes I was a little shy in asking that question, but it's really critical to ask that question to kind of get you into that differential. So Sexual history, painless versus painful, trauma, burns, those are the kind of things that are right at the top of my list that I got to ask.
Yeah, I think those are all great. And was there some kind of accidental injury with the zipper or something like that that maybe is embarrassing to talk about, getting into those things? You're right, painless. A painless lesion, they probably wouldn't come in with that, but that makes you think of syphilis and a chancre. Probably one of the more common painful lesions would be herpes.
Right.
And that may or may not be related to recent sexual activity. It could be a flare up from the past. So that's something that's certainly on my differential as well. This gentleman tells you, and he's like, as you start asking these sexual questions, he's like, hold up. I'm not sexually active. Okay. I'm not sexually active, and I haven't been for a while. I go to dialysis every week. That's my main social activity. So he is a patient who's been on dialysis for a while. Does that change your differential at all or make you think of other things?
Well, I mean, now you're talking about a little bit of a different kind of patient, right? There's obviously going to be a lot of issues around dialysis. You think about vascular issues. So could this be like a vasculitis? That would be kind of on my list of things. Now, I would not have come up with this diagnosis myself, but it was just a couple of years ago that Jess talked about calciphylaxis. Now, I've never seen calciphylaxis. I've definitely not seen it of the penis, so I don't know if that can even happen. But I would definitely be a little bit more focused on vascular causes at this point, knowing that this patient is a vasculopath. They're a hemodialysis patient.
Absolutely. I think that's exactly right. Vascular issues kind of come to the top of the list. And so as you look at this wound, you see sort of around the head of the penis, there's a black area. There's this kind of open wound. It's very tender to touch. It's very painful for him. He's been dealing with this for a while, and it almost looks, gangrenous, right? This black area, which obviously is concerning to him and also concerning to you. But I agree that you've got the tip of the penis, so obviously a vascular distribution with this chronic wound, and calciphylaxis also comes to mind. Now, you probably have seen it in the sense, when you look at an x-ray of one of these, vasculopaths or someone who's dialysis patient, you see those calcium outlines of the vessels on the x-ray. That's basically, if you think about calciphylaxis, think about that x-ray, because what it really is calcium deposits in the arterioles. It's the other name for calciphylaxis is calcific uremic arterial disease. So if you think of that calcium precipitating there, calcium's nasty, right? It's hard. We can see it. That's really what's going on here, Swami.
So this is interesting. And I do want to make a little bit of a reference back to some other things that we should be thinking of. Anytime someone comes in with penile or genital pain, you got to think about necrotizing fasciitis. So this patient looks way too good to be necrotizing fasciitis. That's usually not a 5-month process. Usually vital signs aren't stable, but we got to at least consider that as a possible diagnosis. But yeah, I mean, this looks like a vascular thing. Calciphylaxis has to be up there. And if I remember right from Jess's piece on this, I think it was October 2022, she kind of talked about how, yes, this is very painful. It's very hard to treat, very hard to manage. And so we really have to think about kind of that pathophysiology. So just as a little bit of a reminder, Jan, how does this happen? How do you get calciphylaxis anywhere? And I got to think that penile calciphylaxis is pretty uncommon.
Yeah, this is pretty rare, but in that piece and that Jess did, which is a great reminder, if you haven't reviewed calciphylaxis, go back and listen to that piece. But basically, these are calcium deposits that happen throughout the arterial system, and they can cause rashes. So this could be, if you see a painful rash in a dialysis patient, please think about calciphylaxis. But this is a problem with calcium and phosphate balance, which happens in patients with renal disease because it's your kidneys that really determine that balance, along with your parathyroid hormone. That's also the big hormone that plays a role here. But basically, as your calcium levels rise and your calcium phosphate balance is off, you get these calcium deposits causing this vasculitis. It can look like a lot of things. It can look like purpura. It can look like, larger patches of bruising. It can open up and be open wounds. It can look in a lot of different ways. It's usually on lower extremities, but could be anywhere. Commonly misdiagnosed as cellulitis, of course. That would be one of the first things we think of. But it can turn into these painful necrotic ulcerations due to the calcium phosphorus imbalance.
All right, so the calcium is the issue. Obviously, these patients have a lot of electrolyte issues. So I guess what we have to kind of come back to, Jan, is how do I prevent it? Because I know treatment is kind of hard. In the moment, we're going to take care of the patient's pain. We're probably going to call some consults to get definitive diagnosis, maybe even a biopsy, those kind of things. But how do I prevent the patient from getting this in the first place?
Right. And from the emergency department, probably not something we're thinking about all the
Right.
time. But in terms of what nephrologists are thinking about, they are thinking about this calcium balance. You see a lot of dialysis patients who are on these phosphorus binding agents, and that's because they have these issues, that because their kidneys don't work, this balance of calcium and phosphorus is an issue for them. And this is one of the rare complications of that. So, we can check calcium levels, but they usually aren't systemically hypercalcemic. That's not really the issue. It's really a local problem. And one of the things that I was told once by a nephrologist, this is one reason that nephrologists don't love us to be pushing calcium willy-nilly in dialysis patients. So that when you see hyperkalemia, which is very common in these patients, to be very judicious in pushing calcium. There's no direct link that I could find between the calcium pushes that we give for life-threatening hyperkalemia and development of calciphylaxis. So don't misinterpret what I'm saying. But overall, just pushing calcium in a patient like this, they have these problems with balancing their calcium and dealing with calcium in the vascular disease environment they live in. So it's one thing that changed my practice a little bit when I think about just pushing calcium, for example, for peak T waves in a patient who probably has that very frequently. Be careful with doing that because, this may be a consequence. But again, I think the bigger picture is just their general calcium phosphorus balance. And their nephrologist really has to kind of deal with that. They can do extra dialysis runs if needed, or they can do different things to bind calcium and phosphate.
We actually have a piece next week about calcium and hyperkalemia. I think this what reminds us is you got to look for those ECG changes before you're going in with the calcium, especially on these dialysis patients. Again, understanding, like you said, we don't know that this is causing the calciphylaxis, but it's probably not helping. So It's something that we can hold off on. So Jan, in the patient in front of you, obviously you're going to give them some analgesics, but what else is indicated in terms of management?
Yeah, I think that was the big question, which is what else can we do for this patient? It's very, very painful. There's obviously a pain management component to this, but really it boils down to good wound care. Despite the fact that these are very painful open wounds, there's not much more you can do besides supportive care. They might need debridement. You have to rule out super infection, of course. That could happen in an open wound. And then just giving good wound care, whether it's with these wound care solutions, these balanced solutions that you wash it with, etc. There's not a lot else that you can do except for, like you said, prevention and then just excellent wound care.
Our hospital just got a wound care clinic that we can feed patients into. This is a good group to get into that kind of a follow-up system. If you have a wound care specialist in your system, refer them there because they really need close monitoring to make sure that that wound doesn't become, like you said, infected or become more of a problem. And they can also help kind of as these wounds pop up to take care of them. So you really want that involved a nephrologist and then kind of go from there. But this is a really tough diagnosis because it's tough to make and then it's tough to know what to do with anyway. So it really is about that prevention side of it, talking to your nephrologist, talking to the patient, again, considering where we can maybe hold back on those medications. But other than that, we don't really have much to go on here.
I think that's right. If you're not sure what it is, a biopsy can help. It's not required to make this diagnosis. It's a clinical diagnosis. So there are no definitive tests that you can send. I wouldn't recommend sending calcium levels, et cetera. That doesn't nail the diagnosis. It's a process that happens over time. But making sure that you rule out things like you mentioned, Fournier's, all the serious stuff, and they are vascular patients, so making sure you have good pulses, that you're not talking about ischemia that can be reversed. But outside of that, this is a irreversible process and just needs to be dealt with on a wound care and pain management basis.
Yeah, this is kind of a classic fast track kind of situation where it's like, I'm in fast track. I'm going to see some ankle sprains, some laceration repairs, maybe an abscess or two to drain. And then you get this and you're like, whoa, all right. Okay, well, we'll figure this out. And I feel like most of your cases come from fast track. I think you had a VTAC that was in fast track once. I mean, all you need to do now is like, the other day I got this patient who couldn't breathe, so I criked him in fast track. Like, that's what I'm waiting for. I'm waiting for the fast track crike. So let's make that happen, Jan.
Okay, I'm going to look for that case. I'm going to bring it to you when it happens because it'll happen.
I can't wait.
Yeah. Oh, and also precipitous deliveries in fast track. That's a real good one.
Right.
Yeah.
Well, often the fast track is like the closest to the waiting room. Like you pass fast track to go to the main emergency department. So like, let's just stop here. There's a doc right there. We'll deliver right here. That seems like a great idea. All right, Jen, well, let's get into the week because we have some fantastic stuff lined up this week. We've got our risk management segment with Mike Weinstock. He's got Gita Pensa on. They're talking about the experience when you actually get named in a lawsuit, something that we're all going to face, so we might as well learn how to take care of it and deal with that situation. We've got a rural medicine piece talking about Brash syndrome, which is a fantastic diagnosis. But before we get into all of that stuff, let's hit a couple of papers from last month's EMA.